Great. Thank you for your introduction and kind words, Dr. Meltzer, and for Dr. King to allow us to showcase the good work that we do here in the pain management clinic. As mentioned, today I'm going to be talking about common pain procedures that we offer to patients, and then also briefly touch upon some of the procedures that we don't offer as frequently, but can potentially be an option for patients. I have no financial disclosures for today's talk. And my goal for today's talk is multi-purpose. So the purpose of this talk is, one, to introduce you to common pain procedures that we offer. And the goal is to give this presentation from the patient perspective and common patient's questions that we often received. So some of these are, what are the indications and what are the reasons why a patient might be a candidate for the procedure? What are the risks? No procedure is without any risk. And most importantly, what most patients care about, and we as clinicians care about, is the timeline of benefits. If I do this procedure and it goes well, how long can I expect it to last for? Before jumping into the procedures, I want to take some time to acknowledge the impact that chronic pain has in our society. So this article in JAMA in 2019 highlighted the impact that chronic pain has in our society. So it was estimated that roughly 1 in 3 Americans suffer from chronic pain. And the cost of chronic pain in our society is estimated from $560 to $635 billion annually. And that's broken down from a composition of missed work days that patients experience, having a reduced work schedule, having lower wages, and then the cost of obtaining medical treatment or accessing the healthcare system for chronic pain. Interestingly, chronic pain costs our medical system more than heart disease, cancer, and diabetes combined. The important thing to take into account with chronic pain and our approach here at Stanford is to have a multidisciplinary approach. So what does that mean exactly, and what does that entail? Oftentimes, we refer to this in our clinic as the 4 legs of a chair or the foundations of pain treatment. So what that entails and things that we offer here is, one, medications. So there's different types of medications that we can offer depending on what we think the underlying pain conditions is. Oftentimes, a lot of these medications are medications that may have concomitant properties. So for example, they may serve as antidepressant medications, but also have pain relief properties. They may also initially have been studied for anticonvulsant properties or to prevent seizures, but with time, they've been also shown to have analgesic properties. And then there's other sorts of medications that we offer patients depending on what we think the underlying condition is. We also understand the importance and work very closely with physical therapists. We are very fortunate to have pain physical therapists within Stanford that focus on and work specifically and understand patients that live with chronic pain. And as our colleagues, Dr. Meltzer, Dr. King, who are here tonight, they are great parts of the team and the approach here at Stanford and help provide psychosocial services to our patients and help us of the medical team have a bigger insight into the patient's pain journey and help us determine what treatments can be more appropriate for patients and be more efficacious. And then lastly, the focus of today's talk is going to be procedures that we offer, with the focus being on the most common procedures that we perform, and slight introduction to more complicated procedures that we offer. And throughout this talk, I want you to remember that although we are focusing on procedures today, the treatment of pain should be multifactorial, to include all these aspects in a patient's care. So I'm going to kind of highlight the different types of interventions that we offer. We're going to start talking about from least invasive to more invasive. So that includes trigger point injections, which I'll discuss briefly on what those are, what are some of the indications, what are some of the risks, and what are some of the expected benefits that we expect patients to have from trigger point injections. The other type of procedures we perform are steroid injections, and these can be injections in essentially a lot of body parts throughout the body. They can be in the epidural space. They can be in a joint such as a hip or the shoulder. They can be in the bursa surrounding the hip, which is a fluid that lines and gives the smoothness of the joint. It can be in tendons. It can be in nerves. So we can deposit steroids in all these different places in the body. Nerve treatments, which we will talk about as well. So we can either heat up a nerve, we can cool or freeze the nerve, or we can actually give alcohol or phenol to essentially denature, destroy the nerve. And we will talk about when we think about one versus another. There's also the sympathetic nervous system, which is our natural fight or flight response that has been elevated in certain pain conditions, such as in CRPS. So we can target that. And now we're getting into some of the procedures that we offer that we don't do as frequently, but we'll introduce briefly tonight. There's different implantable devices that we can do, and some minimally invasive spine procedures. Again, these we don't do as frequently or commonly, but it's something that if the patient is a candidate, we can also offer. So starting with trigger point injections. So what are they, and when do we do them? So the main indication for trigger point injections is myofascial pain. So what does that mean? That essentially is pain that we think originates from a muscle or from a muscle tendinous attachment. So patients get trigger points most commonly when the muscle becomes supramaxillary contracted. So that can be if a patient is lifting something really heavy and the muscle contracts more than it's used to or more than it's supposed to. If you're in a trauma, for example, in a car accident, and then you have a whiplash mechanism of your neck, that can also cause myofascial pain, and you can get it really in any muscle group in the body. Most commonly, it's in the neck and in the lower back. To perform the trigger point injections, we can do it via two ways. One, using an ultrasound. And the great thing about the ultrasound is that it helps know where our needle is at all times. And it also shows us where the muscle belly is. So by using the ultrasound, we can, one, assure that we are targeting the correct muscle. And then two, we can make sure that we avoid structures that we want to avoid. For example, when we do trigger point injections in your thorax or in the middle aspect of your back, we have our lungs there. So by using the ultrasound, we can make sure that we stay far away from the lungs, but that we go in the correct muscle group and deposit the medication. So with the trigger point injection, we use a needle and we use a local anesthetic medication, and how it works is via two ways. So the local anesthetic or the numbing medication will help with more immediate relief of the muscle pain itself, and the actual act of the dry needling helps break up the tautness of the muscle and the trigger points in the top muscle bands. And then the other way we can also perform the trigger point injection is just by anatomy and palpation. So in regions of the body where there's, minimal or not structures that we necessarily need to avoid. For example, in the lower back, that's a pretty safe area where there isn't, lung, where there isn't large vessels passing through, that we need to use ultrasound. But oftentimes, we use ultrasound for any of these muscle groups, and it's really to confirm that our depth of the needle targeted the correct muscle. And this is just a infographic here showing, you can get trigger point injections in different muscle groups throughout the body, and it's a simple procedure that we perform in office. We'll have you, our schedulers will give you a call. They'll bring you into a specific room in our clinic where we do this procedure. We'll put some cleaning solution in that area, and then we'll use the ultrasound to guide our needle placement. And oftentimes we like to do a series of 3 injections before, we can really assess if it was helpful or not helpful. The next type of procedures that we do are steroid injections. And then, as I mentioned earlier, these steroid injections we do in different places of the body. So we do them in the spine, we do them in joints, we do them where in previous surgical scars, and we also administrate steroids in nerves. And there's different types of steroids that we use. Some of the common ones are shown here on the left, and depending what part of the body that you're working with, some steroids are more appropriate than others to use. For example, if we work in the neck area, we use dexamethasone. In the spine, in the lower back, we often use depomedrol, and there's different reasonings for that. And oftentimes, it's really most because of the safety profile of these medication. Probably the most common procedure that we do is an epidural steroid injection. And what that is essentially is we're depositing the steroid in the epidural space. And when do we think about doing this for patients? So the indications for epidural steroid injections is what we call radiculopathy, or it's a fancy word, essentially for what most people recognize in society as being a sciatica. So it's usually shooting pain down the leg. It's pain and numbness in a specific nerve distribution, and we figure that out via a combination of history, specific exam maneuvers, and doing an MRI to know what nerve or what disc is being affected, and that's how we plan what level to give the steroid injection. Also, we commonly do this for spinal stenosis. So what that is, essentially, it's narrowing of where your spinal cord passes through. So there's both central spinal stenosis, which is where the spinal cord passes through, or there's foraminal stenosis, which is where the nerve root exits off on the side. So depending on where the stenosis is, that will help us decide what type of steroid injection we perform. For some patients that will have what we call axial back or neck pain, which is essentially just focal pain in the neck or focal pain in the back that doesn't radiate anywhere. If the patient has had physical therapy and different treatments, some providers will consider doing an epidural steroid injection. However, there's no real strong evidence that makes this a definite indication. So some people might offer it, some people may not, but really the two indications that we offer it for, as mentioned, is the radiculopathy and spinal stenosis. To do these procedures, we use a fluoroscopy machine, or it's a special, you can think about it like a low-dose X-ray machine that helps guide our needle during the procedure. And there's different ways that we can administer this injection. So it's administering the medication just posterior to the spine and the spinal cord, which is an interlaminar approach. there's coming from this from the side, which is coming through the foramen or a side approach, and lastly, there's also coming all the way from your sacrum or lower down, which is the caudal approach. And the approach we pick varies on multiple things, but some other things that it varies on is if you've had previous surgery in the area and might have adhesions in that area, might not be a good idea to do an interlaminar approach. It might have to come from give the medication where there hasn't been surgery in that area. And this is a brief description. So as mentioned, when we do an epidural, steroid injections, there's different approaches. The interlaminar is just really coming from behind the spinal cord. The transforaminal is coming from the side, and the caudal is coming all the way lower down from the sacrum. So if patient is a candidate for an epidural steroid injection, what can you expect as a patient? So we have several checkpoints in this process to make sure that this procedure is done safely. So oftentimes you'll get a call from our scheduler to schedule the procedure, and then subsequently we'll have a checkpoint where a registered nurse or one of our APPs gives you a call just to make sure that if you needed to hold any specific medications before the procedure, most commonly it's a blood thinning medication that we have patients hold before the procedure just because it could increase the risk of bleeding. You'll get that call beforehand. The day of, you'll come to one of our fluoroscopy rooms or our surgical suites where we perform these procedures, and then we'll meet you in the pre-op waiting room. We'll go ahead, have a checkpoint to make sure that you didn't have anything to eat or drink after midnight, that all the medications that needed to be stopped were stopped, to answer any questions, and to again revisit the procedure that we're doing. And after that, we'll get you into our fluoroscopy suite where we do these procedures. And this is not the exact room, but it has a similar layout. Again, so this machine here is our CR machine that helps guide our needle. There's a screen there that we use as reference when we're moving the needle. We'll have you position in the table as shown here. We'll clean the area with a special cleaning solution, and we'll then give some numbing medication at the site where we're going to give the epidural steroid injection, and then we'll start taking these pictures. So there's two pictures shown here. The first picture on the left here is what we call a AP view, or just a direct view viewing the spine from up top, as shown in the picture here. And what that helps us do is it helps us make sure that we don't stray too far to the left or to the right, and we're going centrally in the direction that we want to. The picture to the right helps us assess our depth to make sure that we don't put the needle too far in, or that we don't give the medication too early when we're not in the epidural space. And if there's different checkpoints throughout this to make sure that we are in the correct space as we're advancing the needle, there's a special syringe that we use, what we call loss of resistance syringe. And what that loss of resistance syringe allows us to know is when we have entered the epidural space. Before entering the epidural space, there's a ligament that we have to go through to access the epidural space. And after you go through the ligament, the syringe essentially goes from being very taut or tight to having no resistance in the syringe. And then we also inject this dye or contrast, and this is the spread that we usually see when we are in the correct location. And then once we're in that correct location, we go ahead and administer the medication, the steroid. This is the other technique or approach that we do, and this is coming from the foramen or the side view. Again, we use a picture on the left to make sure that we're not straying too far to the left or the right, and the picture on the right to make sure that we're not going too deep or too shallow. And again, we have different checkpoints throughout this process, such as giving the contrast to make sure we're in the right location. In this, when we do this procedure here, we don't use the loss of resistance syringe, because the loss of resistance syringe only helps us when there's ligament presence. And in the side where the foramen is, there's no ligament present, so it's not helpful to use, because you wouldn't be able to tell if there was a change in the resistance, because that's based off of the ligament. And then this last one on the right is what I mentioned is the third way to administer an epidural, which is the caudal epidural steroid injection. So this one, we actually go all the way down to the sacrum and the sacral hiatus, and then we'll place the needle here, and then we'll thread a small little kind of plastic tubing or catheter to the specific area that we want to target. And again, we'll inject contrast to make sure that we're in the right space, and I'll highlight it. And then after we know we're in the right place, we'll go ahead and give the medication. And typically this is the needle that we use for the interlaminar epidural steroid injection in the bottom left. And then this is right next to it is the loss of resistance syringe that I talked about earlier. As mentioned, no procedure is without any risk, and a recurrent risk for pretty much all the procedures I'm going to talk about. And you'll see the recurrent theme is there's the risk of bleeding. Uniquely to epidural steroid injections is what we call a post-oral puncture headache. So that occurs if the needle advances too far and makes a small tear. It can cause some leakage of CSF fluid and can cause headaches. Most of the time, these resolve probably about 80% of time without any interventions. But if they don't, then there's also a separate procedure that can be done to help with the symptoms and help seal the little tear that was created. There's damage to surrounding structures such as nerves, damage to the spinal cord, risk of injection to a vessel, but that's why we use the contrast. So when we inject the contrast at the checkpoint to make sure that it's not going into a vessel and it's going into the correct location, there's a risk of infection. So now, when getting these procedures, here's some of the common patient questions that we often get asked. So one is restrictions after the procedure. So the day of, it's important to not overexert yourself and to take it easy over the next 24 hours or so. After the 24-hour period, you can go ahead and shower, but until after 72 hours, that's when you could essentially submerge in a body of water. So meaning you can't take a bath, go swimming in a pool, go in a hot tub, go swimming in the ocean until 72 hours have passed. And the reason being is with the introduction of these needles, there's small little openings in the skin that do happen because of the introduction of the needle, and it helps, you want to reduce any risk of infection. When can I expect benefits? So a lot of these things are going to be patient dependent, but for a general rule, the benefits from an epidural steroid injection can be as early as 3 days, but the peak benefits to know if it's going to work or not is usually in 2 weeks. How long will they last? Again, this is a question that's patient dependent. Different patients respond differently to these. They can last, for some patients, they last several weeks. For other patients, they can last up to a year or 2 years, or they might just have receive one injection and we might not ever see them again. But on average, we'd say steroid injections last for, let's say, 4 to 6 months or so. And then how often can I get the steroid injection? Like I mentioned, no procedure or medications are without any risk. Steroid injections can increase your blood sugar. They can cause delayed wound healing. They can suppress your immune system. And these are all things that we take into account when deciding if a patient would be a candidate and if the benefits outweigh the risk. But you can get a steroid injection if needed about every 3 to 4 months. Again, the next place that we can inject steroids is in joints, bursa, or tendons. So when we think about if a patient is a candidate for this, so if indications are, for example, if there's osteoarthritis or degeneration in a specific joint, for example, in the hip, in the shoulder, if there's inflammation in the surrounding fluid where the joint is lined by, or there's inflammation in the tendons surrounding tendons in the body. When we do these injections, again, we do these using an ultrasound, or we do it using the special kind of low dose X-ray machine that we use. And so, what can patients expect if you're scheduled for one of these injections? It depends if it's going to be done via an ultrasound or via fluoroscopy machine. If it's via an ultrasound, we can actually do these injections in our clinic. If it's in the fluoroscopy machine, we'd have to do it in the operating room. But similarly, you'll have kind of all the similar checkpoints. So you'll make sure that you're off of the medications that you need to be off of. We'll go ahead and bring you to the room, positioning you in the correct position depending on what joint we're working on. Clean the area, inject numbing medication in the skin before doing the actual injection in the joint. And then here are shown two pictures of a hip injection. So on the left is if we use if it's fluoroscopic guided, and on the right is if we use an ultrasound, and we can do these either way. And just below that is an injection of the shoulder. Again, on the left is using fluoroscopic guidance, and on the right is using ultrasound guidance. Some of the potential complications. So as we talked about, anytime we're introducing a needle into the body, there's a risk of infection, bleeding, damage to any surrounding structures. And one of the things with steroids, especially if injected into a tendon or muscle, there's a risk of atrophy or weakening that area there. The other type of procedure that we do is targeting a nerve. So far we've targeted the epidural space. We targeted the different joints or tendons or bursa in the body. So one of the next targets that we can target is nerves. So commonly we do this if there's inflammation in the nerve or neuritis, or as a diagnostic to know if the pain is originating from that nerve. And that helps us pursue the next step, which I'll talk about later in the presentation, which is some of the special nerve treatments that we offer. And for these nerve injections, we can use ultrasound or fluoroscopic guidance. One of the most common peripheral nerve injections that we do is what we call the medial branch block. But essentially what that is it's this small little nerve that courses here through this joint, which is your facet joint. So oftentimes patients can have degeneration or arthritis in that area there, and the nerve passes through just lateral to that articulation there. So it can, if that joint gets inflamed or irritated, the nerve picks up all the sensation and can cause pain. Specifically, this pain presents as what we call axial neck or back pain, which is really just focal pain in that area that doesn't radiate or go anywhere in the body. And of course, we determine if a patient is a candidate for this, the combination of things. So getting the history, what do you describe the pain as, what makes the pain better or worse, doing specific exam maneuvers, and getting imaging of the joint. We do this injection or procedure using our fluoroscopy machine and fluoroscopic guidance. One of the other common targets that we have for peripheral nerves is the nerves that supply the knee, and there's multiple nerves that supply sensation to the knee, which are highlighted in this image here. There's there's a nerve here in the superior lateral portion, the superior medial, and inferior lateral. And the important thing to know when we're doing any of these procedures, when we're blocking a nerve or treating a nerve, we want to make sure that the nerve is only providing sensation to that area and not any motor or strength function, right? Because we don't want to essentially take out the nerve, and if we give medication or treatment that's going to essentially take out the nerve, you would lose function, your ability to move that area. So we're very meticulous when deciding the locations that we do this. Only the sensation is affected and not your strength or your ability to move a certain part of the body. For this specific block, the indications are if there's arthritis of the knee, and they've tried other measures, so physical therapy, medications, steroid injection to the knee itself. Additionally, some patients can have a knee replacement, and even after the knee replacement, they can have ongoing pain in the area, and those patients are a candidate for this nerve block as well. We can do this either using an ultrasound or using fluoroscopy guidance. And some complications, potential complications, as mentioned, is infection, bleeding, nerve damage surrounding to nearby structures, or prolonged duration of the anesthetic or medication. The next procedure that we offer to patients or treatment is different nerve treatment. So we can give steroid with the local anesthetic. We can also do different types of nerve treatments or ablation. So there's the continuous radiofrequency ablation, which in simple terms, we heat up the probe, and that heating up the probe helps block essentially heat up the nerve and cause a lesion in the nerve to prevent pain signaling. We can cool the nerve or cryoablation and also disrupt the pain pathway that way. And then lastly, we can actually inject a specific type of alcohol or phenol that can destroy the nerve or cause neurolysis. There's also other different techniques that we can do for nerves, and some of these is a different type of radiofrequency, where instead of giving a continuous treatment throughout the whole time, they'll give a couple seconds of treatment, stop, couple seconds of treatment, stop. And the difference between the continuous and the post radiofrequency is with the continuous, the temperature that we're doing the treatment is much higher, so it actually causes a lesion or destruction of the nerve signaling pathway. And in the post radiofrequency, it doesn't cause any actual lesioning to the nerve. And this is essentially what the radiofrequency looks like. So it's similar to the procedures that we talked about earlier, but the difference is when we place the needles, we use a specific probe within the needle that we can connect it to a machine, and we can choose the temperature that we want to put the probe to. So we know between 60 to 80 degrees Celsius is the temperature that can cause nerve or tissue destruction. So oftentimes we would place the temperature to 80 degrees Celsius, depending on the area that we're working with. We'll set it for a minute and a half or 2 minutes and start the treatment. Again, before starting the treatment, we want to make sure, one, that the nerve is the cause of the pain. So that's why we do those diagnostic injections that we talked about before, and that's only with numbing medication. And then now, once we confirm that the pain is coming from that source, we put the specific probe, which we heat up the tissue and cause a lesion in the nerve. Oftentimes, the nerves do regenerate over time, but this gives you a longer lasting treatment than if we were just to inject numbing medication or inject numbing medication with the steroid. The picture on the top right is doing the radiofrequency ablation of the medial branch nerves. And then the picture on the bottom right is doing the nerve that's around the knee. And then one of the other types of treatments that that we offer specifically for nerves is, like I mentioned, is this pulse radiofrequency. And the difference, as mentioned, was with the pulse radiofrequency, you're giving some treatment at a lower temperature, then you stop, then you give some treatment, and then you stop. And then with the continuous, it's a treatment at a higher temperature for a continuous duration. And when we think about this type of treatment, we think about it for nerve pain or neuropathic pain. So you can have neuropathic pain for many different reasons. Some of the common ones that we see here is if there's a specific nerve in the body that for a reason is inflamed or irritated. So that can be nerves that line your ribs or intercostal neuralgia, nerves that provide sensation to the back of your head, or occipital neuralgia. And we can target all these different nerves and provide this treatment. Some of the complications that can happen from these treatments, similarly to what we had previously talked about before, but one of the ones that is more unique to this is what's called neuritis, or inflammation of the nerve after the treatment. To prevent this, we often give steroids to help prevent any inflammation after the procedure. However, it does happen. Luckily, it's not very frequent that this occurs. Some of the common patient questions that we have after these ablations or specific nerve treatments are, again, we want to know what are the things I can and cannot do after the procedure. So similarly, the day of, you're going to take it easy over the next 24 hours. Or after the 24 hours, you can take a shower, but until 72 hours pass, there's no submersion in any type of body of water. When can I expect benefit? Again, this is patient dependent. Some patients can feel benefit and relief right after the procedure, but the peak benefit, so we know if it worked or it did not work, is in 4 weeks. How long will it last? Again, it's patient dependent. For some patients, it can last 6 months. For other patients, it can last a year or 2 years. But on average, I would say most patients say a radiofrequency ablation helped anywhere from 6 months to a year. And how often can I get and radiofrequency ablation? It's about every 6 months. So far I've highlighted the common procedures that we offer, and over the next couple of slides, I'll talk about some of the less common procedures that we do, but is still we can still provide for patients if they are the appropriate candidate. So the blockade of the sympathetic or parasympathetic nervous system. This is essentially doing a blockade of the sympathetic nerve system, and we know that the ganglion of the sympathetic nerve system passes just anterior here to the vertebral body. So we'll place our needle as close to that area, inject contrast to make sure we're in the right place, and then give the appropriate medication. There's different devices that we can do. And again, this is, of course, when we're implanting or considering for that, we want to make sure that the most important thing for any of these interventions is to make sure that the patient is an appropriate candidate and that they're going to have that we all believe that they're going to have a good response to it. So this is implantation of the spinal cord stimulator and the leads. There's different indications for this, but some of them are if a patient had a surgery, a back surgery, and they have ongoing pain, if they have CRPS or complex regional pain syndrome, if they have really bad diabetic neuropathy, that they've essentially tried every other medication and every other treatment, and this is kind of the last the end of the line for them. And what's really neat or good before doing any of this, the implantation and stuff, there's a trial period where we place the leads for 1 week, and if they work, then we can move on to actually placing the generator and the device as well. And if they don't, we just pull them out, and we know that the patient would likely not get benefit from the implant. And there's other different types of stimulators that we can do for patients as well. This is a peripheral nerve stimulator, so it's much smaller, and we commonly do this for patients that have mononeuropathy, or so a single, or we can trace the pain or the etiology to a single nerve. And then again, before we doing this, we target that nerve just using a nerve block. And if they get the appropriate response, and taking other factors into account, we can potentially offer this therapy to a patient. And then lastly, more for patients that have cancer and may require high doses of opioid medications, but they might have difficulty taking the medication because of side effects. We can consider doing a specific way to deliver the medication with the least amount of side effects, which would be essentially by placing a catheter into a specific space in the spine, which is called the intrathecal space. And some other less common procedures that we do, but as mentioned, we can still offer them. So there's direct lumbar decompression, but what that essentially is patients that have spinal stenosis and have what we call neurogenic claudication, or pain or symptoms with walking. They could potentially be a candidate for this procedure, but that's only if they have a really thickened ligament or a large ligament on their MRI or imaging. And the reason being, because in this procedure, we essentially go and use a specific device to take off small scoops of the ligament to allow more space in the spinal cord, and to relieve some of the narrowing in that area. Additionally, there's other ways to decompress or in the spine, and this is it's called vertiflex or interspinous spacers, or we can put this small little device in the spine, and there's a small incision that we make, and what that does, it helps kind of stabilize and reduce the stenosis in the area, from preventing the spine from collapsing and reducing the space. And then lastly, there's also kind of similarly to some of the ablations we talked about before in the peripheral nerves in the back or other areas of the body. But in this one, we actually can get access to the nerve inside of the bone in your back and your spine, and heat up that nerve inside there using specific tools and via the intercept or basovertebral nerve ablation. So hopefully that highlights, some of the potential therapies that we can offer patients. I just want to again emphasize the importance of the multidisciplinary approach. So today I talked about the procedures, which are important. However, for patients to get the best results and the best treatment, it should be a combination of all these things. So thinking about what medications can be beneficial for patients, making sure that they're strengthening the muscles and making sure that they're staying physically active, making sure that if they have previous life experience or traumatic events that affect them emotionally and psychologically, that they are receiving the appropriate therapy or the appropriate medications for that. And then lastly, if they are a candidate for procedures, to make sure that there's the proper workup beforehand. Lastly, these are just some resources that Stanford offers. As mentioned, we have an excellent pain psychology team here that we're fortunate to have at Stanford and work closely with. And there's also different support groups in our community, which are highlighted on this slide. And then here are my references for this talk. And with that, we can go ahead and move over to our Q&A portion of tonight's talk.